And welcome to the presentation on steroids and a little bit of drug calculation. So the big thing here is to understand in the context of systemic steroids and inhaled corticosteroids for respiratory context. There's a lot more applications for systemic steroids than what we'll talk about here, but primarily we'll talk about it in the respiratory context. So let's get started. All right, so let's talk about corticosteroids and their physiology. There are a group of chemicals secreted by the adrenal cortex hormones, and then we're looking at these being secreted from the adrenal medulla. Remember, medulla means middle, and then cortex means covering. So when we're looking at the adrenal gland, it's composed of two areas, the adrenal medulla, which is the inner zone or the middle part, right? Remember, medulla means middle, and this produces epinephrine. When we're looking at the adrenal cortex, this next part here, it's the outer zone, which is the source of the corticosteroid. There are three types of corticosteroids, which is this next one here. So these three types of corticosteroids are produced at the adrenal cortex. The adrenal cortex, which is this part here, number 2. So there are three types of corticosteroids. It sounds like you need to know all three of these, and you do. All right, there's the glucocorticoids, the mineralocorticoids, and the sex hormones. So those are the three that you need to remember. The first one here, the glucocorticoids, this includes cortisol, which is your stress hormone, which you probably have this secreted in your bloodstream during a stressful event, like a test, right? Whatever that you have there that's a stressful event. So that would be cortisol. And cortisol, when we see this, we're kind of using an analog of cortisol when we're giving an inhaled corticosteroid. So they're a synthetic analog when we give an inhaled corticosteroid like your Flovent or Qvar. It's a synthetic analog of the cortisol part, which is a glucocorticoid, right? Glucocorticoid. The next one, number 2 there, the mineralocorticoids. An example of that would be aldosterone. Aldosterone is something that your body makes that regulates water and increases sodium reabsorption in your body. We'll talk a lot about more of that in the diuretics lecture when we start talking about those. So that would be an example of a mineralocorticoid that your adrenal cortex makes. And then finally, the sex hormones. This would be your androgens and your estrogens that are naturally secreted there. So those are some examples of the glucocorticoids, like cortisol, and cortisol would be that one, that glucocorticoid we have a synthetic analog of for your inhaled steroids, inhaled corticosteroids. Aldosterone, which is going to help with sodium reabsorption and regulating water in your body, as well as androgens and estrogens for your sex hormones. So those are the big ones to look at, and make sure that you remember they're from the adrenal cortex. The cortex is the outer zone which produces the corticosteroids, and then the medulla is what produces epinephrine. So there's a difference between what produces epinephrine versus what produces the corticosteroids. So remember, medulla is the middle, the cortex is the covering, the outside, and the covering is the one that does these corticosteroids. All right, so here you see the cortex, right? This is the covering that we're looking at here, the adrenal cortex, and then the medulla would be this middle part here, right? This middle part here, right? That looks like the Star Trek logo, right? Okay, if that doesn't make any sense to you, don't worry about it. But that's what you're looking at here. So the inner medulla produces epinephrine, and the outer cortex is the source of corticosteroid production. When we're looking at this, you have something what's called the HPA axis, or the hypothalamic pituitary adrenal axis, right? So there's all three of those things that are looking at. And so I'll talk about the HPA axis on the next slide, but one of the things that it does, the HPA, right, the hypothalamic pituitary axis, the HPA, it releases cortisol, right, or it releases control. So it releases that cortisol, which allows it to go into the bloodstream. When we're looking at this, respiratory corticosteroids are analogs of cortisol, which is a glucocorticoid. That glucocorticoid is what we're seeing there. So here's your HPA axis, your hypothalamus up here. right, at the top, right? And what's happening here, it produces and controls your endogenous corticosteroids. So this is what's that HPA axis. When you have something like a physical stress that goes on, you're going to have your pituitary, right, that tells, right, the body to release these stress hormones. Well, when we're seeing these stress hormones being released, right, it goes to the adrenal cortex, right? The adrenal cortex then releases glucocorticoids. The glucocorticoids causes gluconeogenesis, protein metabolization, fat metabolization, decreases inflammation, right? Because these are anti-inflammatory steroids, right? As we know, reduce inflammation. Once they do that, they should help relieve that inflammation, that stress, that physical stress thing that goes on, and we send that feedback, right? That feedback, and then that's where we create more or do we stop creating it, right? This is the HPA axis that you're looking at here. So when we're looking at the HPA axis, it produces and controls endogenous corticosteroids. So what happens is this hypothalamus is stimulated, then it releases corticotropin releasing factor, right? And that circulates to the anterior pituitary, which is what we were seeing on that previous slide. And then the corticotropin and the adrenocorticotropin hormone is released. The adrenocorticotropin hormone is released, and that is released into the bloodstream, and then we have that adrenal cortex that gets stimulated, and then we have the glucocorticosteroids that are released, right? And that's what that previous picture is, and that's what circulates it all around the body. So the HPA axis releases cortisol. Well, my next question to you, before we go into this slide deeper, is what happens to glucose? What happens to blood glucose as a response to this? Well, blood sugar will increase, right? Because the whole thing here is to help regulate the metabolism of carbs, fats, and proteins. So your blood sugar should increase with this. So be careful with steroids, especially systemic steroids in people that have severe diabetic issues. Because we could have the increase of glucose on those patients that could not be regulated by their insulin production, because by definition their insulin production is poor or almost non-existent. So we need to be careful if we're giving systemic steroids to someone, even though they might need it, we need to be careful to watch their blood glucose, especially if they have a diabetic situation. But when we're looking at this, sometimes we can have what's called HPA suppression. And that means we're going to have side effects for long-term steroid use, because what happens is your body, we're giving you the steroids physically, right, systemically. What happens is your body says, oh, someone else is supplying me steroids, so it's not going to produce as much on its own, right? It's going to atrophy its own production, if you will. And what can happen is we can have a rebound situation. So there can be what's called HPA suppression, and these can lead to long-term side effects of steroid use as well. So we got to be very careful when we're using these steroids. Traditionally, they don't like you to cycle any more than 2 or 3 systemic steroids per year. After that, there could be risk of things like osteoporosis and other things like that. So we got to be very, very careful. When we're looking at these glucocorticoids, right, we talked about this, glucocorticosteroids really do regulate the metabolism of fats and proteins, right? They provide the body energy, right? So they cause an increase in blood plasma and glucose, and then you can have what's known as steroid diabetes, right? That's from the PO steroid use, so like the oral prednisone, right? The body can't tell the difference between endogenous and exogenous steroids, so that will eventually lead to HPA suppression. All right, now on to this slide, right? When we see this, inflammation is the response of a vascularized tissue injury. Does that include your lungs? Absolutely, right? Your lungs are vascularized tissue. And if they have an injury, of course, you're going to have that inflammatory mediator response, which we've already talked about in our other presentations as well. Just like if you roll your ankle at my Zumba class, right? You're going to have that inflammatory response. So that's something that can happen. Any type of tissue that's vascularized can undergo this response, including your lungs. So what's the response? Well, the general symptoms, you're going to have redness, swelling, heat, and pain. When we're seeing the redness, that's the dilation of the blood vessels. So that's the dilation of the blood vessels going from a smaller diameter to a larger diameter. So that's going to show more vascularity. You're going to have more perfusion there. So that's the dilation there. The swelling will happen within minutes, so it's going to be pretty quickly after that issue. Then you're going to have vasodilation that causes that heat as well, right? Because there's more blood flow in that area, so if there's more blood flow in that area, it's going to be warmer, right? And obviously you're going to have your pain response as part of this. So the process of inflammation that we're looking at here is making sure that we see what's going on here, because you have an increase in vascular permeability, which means you have an exudate that's formed that's surrounding the tissues, which means with the cellular mediators and the exudate, when someone has an inflammatory pneumonia, right, their lungs are inflamed, what happens is they have an exudate that's formed. When they develop ARDS, they have a bunch of cellular mediators that are sloughing off and creating pus in the respiratory zone because there's vascular tissue injury. So it's pretty significant, right? And what happens here is then you'll have what's called the leukocytic infiltration, right? That's what this number 2 down here, leukocytic infiltration. That leukocytic infiltration, what happens there is the white blood cell will go to the site of the injury and it will congregate. It will make a party there. And the whole point of that is to help with eating anything that's bad. Any site that could be injured could have a source of infection. So it's going to go to that white blood cell. That white blood cell is going to go to the site. They're going to congregate there, and they're going to try to help. Does this happen in the lungs as well? Absolutely. Number 3 is the phagocytosis, right? So in the lung, right, because we're talking specifically about the lung, with phagocytosis, in the lung, the white blood cells, the macrophages, will ingest any foreign material that's not supposed to be there. So if you do have a bacterial pneumonia, you'll have that white blood cell and the macrophages, the type 3 pneumocytes, that will come over and try to eat and ingest that foreign material and neutralize it as much as possible. And finally, number 4 is going to be your mediator cascade. And this is usually means your histamine, your chemical attractant factors are released at that site, right? And we're going to have that those cellular mediators be released there to help send more blood flow there, to help cut off any extra things there that could be going on. All right, it's a protection mechanism. But what can happen in the process of this is you can have a hyper responsiveness that then causes the patient to have more harm than good from it as well. So we have to be very careful when it comes to this. There are various causes that we have to look at. The 2 most common causes are chronic asthma and bronchitis when we're looking at this inflammatory response in the lungs, right? So inflammation in the lungs, 2 most common causes are chronic bronchitis and asthma. Now, besides chronic bronchitis and asthma, there are other various causes of inflammation in the lungs, especially trauma here. This can either be a direct trauma, like a pulmonary contusion from a car accident or something else, right, a crush injury, or it could be indirect trauma as well. You'll see patients have what's called direct or indirect ARDS, where one time it's from aspiration of a vomit, right, or something like that, that direct injury. Other times it could be their whole body is just busted, like they got thrown through a car windshield and their whole body is just inflamed, and that inflammatory response goes to their lungs. So that would be an indirect trauma or indirect cause there. So watch out for that. You can see patients, even though their lungs weren't involved in the initial incident, they could still have that inflammatory response in their lungs, even though because it's a systemic situation that's going on. Other things that we're looking at are inhaling toxic substances like chlorine gas inhalation, which I've seen with the lifeguard once, right? Different things like that could have this happen as well. Whether it's on purpose or by accident, it can happen. And then finally, infection, right? Infections are going to be the other big one. And primarily, what's your number one cause of chronic bronchitis? Well, most of the time, it's an infection, right? An infection, right? Repeated infections for chronic bronchitis that eventually causes necrotizing of the tissues, dilation of the tissues, which then lead to emphysematic changes, and then they have something called COPD because now they have airway reactivity, and they have all three of those things. Chronic bronchitis, and it usually causes emphysema, which then causes COPD, right? So we see that cascade there. So the big thing is understanding the inflammation in the lungs. Usually can be direct or indirect. Asthma and chronic bronchitis are the two most common causes. However, you can have trauma, inhaling toxic substances, and or infections that can easily do that. So what's happening here? You can have a mediated cell issue. So when we're looking at these are the cells that cause bronchospasm, right? The second point here, these are the cells that cause bronchospasm, which includes your eosinophils, your basophils, your macrophages. Hey, mast cells, seems like we've talked a lot about those so far. T lymphocytes, and finally, the epithelial and endothelial cells, right? And then the epithelial and endothelial cells here, this last point down here, these cause the most inflammation. These are your troublemakers, if you will, if you have a hypersecretion, right? These cause the most issues there, right? The most inflammation. And then the mast cells and the eosinophils, these two here, they are the two biggest effector cells in the cascade. So if we can avoid eosinophilic release, or we can avoid mast cell destabilization, we can really help control the severity of that asthmatic symptom. So both are types of asthma, right? So when we're looking at the inflammatory or the allergic pathway that goes on with asthma, where we're talking about extrinsic versus intrinsic, that's where we can look at using medications that help stabilize and help limit the effect of the basophils or eosinophils in there. So let's talk about asthma here. So when we're looking at asthma, you can have asthmatic reactions that are considered biphasic, right? And we're going to have both an early and a late response, So asthma includes an early phase, pretty early on, and a late phase. And you'll see this out there. I remember working in pediatrics, and we'd have some asthmatic kids that would come in that were allergic asthma, and they would come in, and we would go ahead and start treatments, and their x-rays clear, right? There's nothing on their x-ray. They don't have anything but a dry cough. And the doctor would order vest therapy. They would order some sort of CPT, and I was always confused by that. And then I asked them about it, and they're like, well, you just wait, right? When the late phase kicks in, they're going to have lots of secretions. Well, sure enough, the next day, right, something like that would happen, and they'd have lots of secretions. So they're sort of biphasic. They have an early phase and a late phase, and it can vary depending on how much exposure there is, how sensitive the tissue is to that responsiveness, right? There's some dependent variables in there. So when we're looking at this, the insult, the early insult is usually caused by IgE. IgE is what usually is the early cause. Here, let me circle it. IgE, right? And when we're looking at this, the insult to the asthmatic airway is usually that immunoglobulin E, and it's activation of those airway mast cells. I'm circling important words here that release inflammatory mediators such as histamine, prostaglandins, PGD2, leukotrienes, those things. When those are released, then you're going to have a response to the airway chemicals such as histamine, which will then cause bronchospasm, right? So the response usually peaks at about 15 minutes, and then it should decline over the next hour after that irritation. So this is after the irritation. And then the early phase decreases is really what decreases expiratory flow rate, right? So in early phase, you'll see that decrease in expiratory flow rates. So if you have an asthmatic that shows up to the emergency department, your big thing there would be to go ahead and get a peak flow, or if they can do it, and look at their flow rates compared to where they are at baseline, if that is possible, or to go ahead and make sure that they are on the right path on their treatment process, because then you can see if they're in their red zone, yellow zone, green zone, right? You can sort of see where they're at as well. So if they're in that early phase, you're going to start to see that decrease in their expiratory flow rate. So when we're looking at this, we're going to see that even with treatments, the progression of these cellular events can continue. Hey, we're giving them their nebulizers. We're giving them a systemic steroid. We're giving them, all this medication, maybe mag sulfate IV, right, to help with magnesium IV, right, to help with really relaxing smooth muscle, right. We're giving them all these things to help out. But there still could be that cellular mediator release. Hey, we're giving them an antihistamine like a Benadryl to help with that histamine release, right? So no matter what, it can still keep going on even though we start the treatment. So they can progress even though they're in our care. So you shouldn't feel defeated if you can't turn around an asthmatic. It would be great if we can, but if we can't turn them around, that's okay as well. We'll just have to do the best we can and leave the rest up to whatever happens. When we're looking at this, the mast cells, which we've talked about a lot so far, mast cells and cytokines, they eventually will recruit other inflammatory cells. So they don't like to do it by themselves, right? They release other cells that then activates the epithelial cells and endothelial cells to release adhesion molecules. And that will cause your late phase reaction. That adhesion molecule will then cause your late phase reaction. So usually 6 to 8 hours is what we're looking at here. So you have your first 15 minutes, you're usually going to get that early phase, their peak flows will be down, and then as they keep on progressing, it can get worse and worse, where now they're activating these adhesion molecules, then that will cause that late response. And this is about 6 to 8 hours after a challenge. So, and it can last up to 24 hours. So is this person going to be reversed right away and be able to be sent home right away? Maybe not, right? Depends how early, how much exposure there is, how sensitive their airways are, right? There's some variability there. But overall, when we're looking at this, that's pretty significant. So one of the things that you think about here with these asthmatic patients is inhaled corticosteroids being a first-line therapy. I know it sounds weird, but there's something that we can do here. They are most effective on long-term, let me circle this, long-term therapy for mild, moderate, severe, persistent. So the first thing, the best thing to control asthma is to do your long-term therapy. It takes at least 3 to 4 weeks for inhaled corticosteroids to be effective on your lung tissue, right? They have to be taken their Flovent twice a day for at least 3 to 4 weeks before it's going to be very effective on their lung tissue. So that's something that you'll see there. And that's something that, yes, we can start it when they show up into the emergency department. We can start it while they're in the hospital, but we got to understand that that's going to be their long-term therapy. That's not something that's going to be built up significantly currently. So it is a first-line therapy at all levels is to make sure that we're doing proper maintenance control, right? So we're looking at long-term. We're use inhaled corticosteroids for long-term therapy, right? And they're even starting to recommend, there's an article that I think I have on Blackboard for you that talks about using inhaled corticosteroids instead of your short-acting beta agonists out there, right? And maybe it's a PRN, short-acting beta agonist, but overall, that long-term inhaled corticosteroid is going to be best for maintenance and control. When we're looking at this, if this person is on inhaled corticosteroids and still has an asthma exacerbation, then we might need a short burst of oral steroids might be needed, right? So this would be your long-term up here, right? And hopefully we have them on that long-term regimen. If they come in and even if they're already on that long-term regimen, we might need to do an oral course of steroids, just a short burst to help regain control. And we're looking at is prednisone and or solumedrol. Solumedrol is the IV version. Prednisone can come in tablets. It can come in liquids. All right, some babies, some kids that will come in. I call everybody babies that are peds. Anyway, some kids that can come in, you can give them oral prednisone. You just got to make sure they don't throw it up, right? So the big thing, solumedrol, it's a prodrug, so it's not really activated till it's, goes through that liver. But when they're looking at this, that's another way to give that systemic steroid. So for an exacerbation, we're looking at systemic steroids. For long-term therapy, inhaled corticosteroids. For acute exacerbation, systemic steroids. For a long-term control and maintenance, inhaled corticosteroids. Right? Hopefully I said that a couple of times on purpose. But remember, inhaled corticosteroids are not for an acute exacerbation, right? Inhaled corticosteroids have no bronchodilating effects, and they take a while to build up in your system, so they're not for acute events. Now, can you still give an inhaled corticosteroid? Can a patient still take their QVAR or Flovent inhaler during an exacerbation? Absolutely they can, but it's not indicated to reverse or anything like that, right? It would just be continuing their maintenance medication. But the big thing here, and I'm going to put this on here, is patient compliance, not lung compliance. Them taking this at home, patient compliance, is going to be your biggest issue. And this is where your patient education needs to be on par. You need to have that game in ready to go, because if that patient's not taking regularly their inhaled corticosteroids at home, then they don't have it built up in their system to help prevent or to help reduce the severity of their exacerbations. And so this is where you can educate them about this being just a topical medication. Yes, there are some side effects like thrush. Yes, you do need to brush your teeth and all that stuff, rinse your mouth after you take these inhaled corticosteroids. But overall, how would you like to have less days where you miss work, less days where you miss school, less days where you feel short of breath, less days where you have to come into the ER, less medical bills associated with it, right? And then making sure that they understand the value of staying compliant with it, because the trouble with maintenance medications and compliance is the patient won't notice traditionally. You have to highlight for them that there is a better chance for them to not have it as severe, a better chance for them not to feel as short of breath, not to have as many issues with their peak flow rates, right? And it's a hard thing to sort of prove unless they can see the difference, and it's hard for maintenance to really show them a difference unless someone points it out to them. So patient education is going to be one of your best things you can do, so that way you just run into them at Target or Walmart, wherever you go, right? That's where you want to see them next. You want to see them in the hospital ER, or maybe you see them in the PFT lab once every 6 months or so to see their PFT results. All right, so let's talk about daily medications in this asthma chart. So this is looking at intermittent asthma, right? Here's your intermittent asthma. And then this is where we consult with an asthma specialist. And this is where we look at step 2 care, step 4 care, so on and so forth. If you go to step 4 care or higher, then they need to see an asthma specialist, right? So step 4 care or higher, they need to see an asthma specialist, which can include a pulmonologist, right? And then if they go to step 3, then it's consider a consultation with someone like a pulmonologist or a specialist there. And so that's something you have to watch out for. So a lot of primary care physicians can easily do step 1, step 2, step 3 care. But when they get to step 3 and they're still having symptoms, they're still having issues, that's when they should consider consulting for a specialist, which would be like a pulmonologist here. Asthma allergy specialist of some sort. But the big thing is making sure that there's on each step, there's patient education. We're looking at their environment and then managing other things like their comorbidities as well. Those are going to be huge things. I just highlighted them. Those are going to be huge things to make sure that this patient not only understands where they're at, but is going to take some ownership as well. They're going to have more empowerment if they understand how this medication works, why we're doing it, what's the value of doing this, right? If they don't know the value of doing their inhaled corticosteroids, it's going to be one of those things that are forgotten and lost, and they're going to feel they are still going to be confused why they're not feeling better, right? Environmental control, if they're still smoking, if they're still in places with pollution, or if it's still smoky outside, if they're still, right, doing all those things, going out on bad air quality days and weather quality days, if we don't have the education, if we don't help manage their comorbidities, they're not going to show that change or that improvement. And that's really our ultimate goal, is to help them have a better daily life and to be more functional without having to worry about these. But when we're looking at that, I want you to see that part of this list. When you get up to a step 4, when I want you to see the treatments here, and this is where we're looking at the short-acting beta agonists as needed for step 1. When you go to step 2 asthma, then they'll start a low-dose inhaled corticosteroid. That could be like a 44 microgram Flovent, 40 microgram Qvar, right, so on and so forth. Or they could try the cromolyn sodium. We talked about this in our last PowerPoint. The cromolyn sodium. They could even try theophylline if they don't react well to that cromolyn. When we go to step 3, that's where they do the LABA plus the inhaled corticosteroid, right? That's something we can look at. Or if they were unwilling to do a LABA plus an inhaled corticosteroid, then they could just up the dose of the inhaled corticosteroid by itself. But remember, a LABA plus an inhaled corticosteroid, long-acting beta agonist plus an inhaled corticosteroid, have that good synergistic effect as well. And so that's something that could work well. It just depends what works best for that patient in that scenario there too. They could always do other things. They could always start Xolutin, right? Or even something like the theophylline, like your xanthine there as well. Step 4, this is where they should be considered for a high level of consult. This is where they make sure that they're at minimum doing a medium dose of inhaled corticosteroids in a LABA, and then we can also add other things there. Then when we get to step 5, look at this. This no longer works for alternatives. It goes to the letter or the word and here, the word and. So they're going to be on high dose, right? This is a big thing here. When they go to step 5, we're going to go to that high dose. 44, 110, 220. They're going to go to that 220 microgram of Flovent, right? And it's that high dose, and then they're going to do that LABA as well. And then they might have to do some things like Xolair or anything like that to help control their allergies as well. And then finally, step 6. We're looking at pretty much everything, right? And considering all these other things for asthma and allergy. So it's going to be looking at their environmental control, their comorbidity conditions, and then we can try to hopefully, if we get them under control, stepping down. We can always titrate back down if we need to. And I think a lot of patients are concerned when we increase the dose of this or add a new medication. Well, if they don't want to be tied to that, they feel like they're going to have to do that the rest of their life, and that's not necessarily true. If their asthma is under better control, then we can always step down as well, right? Step down. So I want you to look at this slide. I want you to look at this and make sure that you sort of understand this is the goal. This is the plan of care. This is the evidence-based care. Sounds like you'll do a chart later on this for this type of patient. So now we're looking at COPD. So that was asthma, this is COPD, and this is where we're going to be looking at gold standards, right? Gold standards, the global initiative on lung disease for each stage of COPD, right? You have your mild, moderate, severe, and very severe stages, and your inflammation pattern really is different than asthma because your basophils and neutrophils are going to be a little bit different. With inhaled corticosteroids really don't work with neutrophils, right? Inhaled corticosteroids really don't work with neutrophils, so that makes it different. Because the basophils, they are your largest granulocyte, and they release histamine and heparin and all that stuff. But neutrophils are the most abundant, right? They're 50 to 70% of your white blood cells are neutrophils. So that's right, 50 to 70% of your white blood cells are neutrophils. Remember, those are used for phagocytosis. They're used for eating all those little bad things that get in there. And they release chemicals that attract other inflammatory cells. So neutrophils aren't affected by inhaled corticosteroids, right? Neutrophils aren't affected by inhaled corticosteroids. And remember, neutrophils are 50% of your 50 to 70% of your white blood cells. That's a lot. So when we're looking at this, you see the different stages here. Mild stage, they're still, 80% are predicted. Let me change the colors here. Let's go to yellow here. 50 to FEV1, FEV1 to FVC, right? We have those issues there, but we're looking at this whole time. Notice this green column here, right? Notice that green column here. Well, the big thing is to help these patients, no matter what stage they're in, is reduce their risk factors for severe pulmonary issues, which includes making sure they got their flu shots, making sure their vaccinations are up to date, and then adding short-acting bronchodilators as needed, right, as needed. So that's there on any stage of this COPD. When we're looking at moderate stage, now we're looking at their FEV 1%, less than 50%. It's 50 to 80% of predicted, right? 50 to 80% of predicted. So that PFT will help us see that there. And then when we get to stage 2, we're also seeing this category down here, and that means we're going to add regular treatment with long-acting bronchodilators, so LABAs, right? And then consider adding pulmonary rehab. I'm a big proponent of pulmonary rehab because that includes education on how to have better activities of daily living, education on their medication. Education, it empowers them. It makes them feel like they're not having to be trapped into their lazy boy chair at home. Right? So I'm a big proponent of here. So when they get to step 2 of COPD or stage 2, that's when we have to make sure that we're looking at things like pulmonary rehab or LABAs in their care. Stage 3, I'm going to have to switch to a different color here. Let's do blue. Stage 3, this is where they're less than 30%, 30 to 50% of their predicted FEV 1%. So that's pretty severe. And this is where we're going to have this new category down here, right? This new category here. This is add inhaled glucocorticoids if repeated exacerbations exist. So if they're not on steroids at that point, that's why we wait till stage 3 on these patients. Remember, it's first inhaled corticosteroids are first line for long-term use in asthma. However, with COPD, it's not till they hit that stage 3, that severe stage 3 COPD, right? That's when they go ahead and think about adding those in. And finally, stage 4, very severe. That's at 30 to 50%. Plus, they have chronic respiratory failure. In other words, their blood gas shows a chronically compensated respiratory acidosis. So that's why in the PFT lab, every once in a while, you'll be doing an arterial blood gas, right? And even home care, they'll do these things every once in a while, but a lot of times they'll have them go into the hospital or PFT lab to do those. Here's the situation. There's a new category that gets added in for this. At the very bottom there, you'll see to add long-term oxygen therapy if they're in chronic failure. That long-term oxygen therapy will help them because they're retaining CO2. Because they're having trouble eliminating CO2, we need to buffet that. We need to compensate for that, and that's going to help them, right? And then considering surgical treatments, that includes removing different parts of the lungs if they're diseased is bad enough, or even lung transplants if it's bad enough as well. So with mechanism of action, we have a lot of stuff to look at here. And the big thing here is inhaled corticosteroids are highly lipophilic, which is a good thing. They're highly lipophilic. So when we're looking at these 3 general reactions, let's talk about them. Number 1 is binding to the drug receptor. So binding to the drug receptor here, and this will induce anti-inflammatory substances So these drug receptors are glucoreceptors. They're glucoreceptors, right? These are glucoreceptors, right? And what happens here is they'll induce anti-inflammatory substances that then triggers the corticosteroids to be produced, right? It triggers the glucocorticosteroids to be produced, right? So when we're looking at this, that's then going to cause number 2 here. We're going to have suppression of inflammation factors, right? Suppression of inflammation factors, which is the whole point here, is to reduce how much swelling is going on. It's not going to stop it completely, but to help regulate it. And then number 3 here is going to have an upregulation of inhibitors that suppress pro-inflammatory proteins. So we're trying to reduce the amount of inflammatory regulation that's going on. That whole point there is to really limit how severe, because yes, the inflammation is a good response to have, but if it's too severe, right, it can cause harm to the patient. And so what we're doing here with these medications, this is the mechanism of action for these medications, is to reduce the binding to the drug receptor, suppress the inflammatory factors, and then upregulate the inhibitors that suppress pro-inflammatory proteins. In other words, stop them from creating more inflammatory proteins. So that should help the patient. When we see this, the white blood cells can have an increase in numbers in these patients. And then what will happen is it should, in time, restore responsiveness to beta-adrenergic stimulation. And I previewed this in other courses before, but this is kind of a big one to pay attention to. Drawing a giant arrow to it. And the whole point is to restore that responsiveness to the beta-adrenergic stimulation. If there's a lot of inflammation going on, the lungs may not be able to respond to beta-2 stimulation, right? To beta-2 stimulation. So you can give them nebulizer after nebulizer after nebulizers, and you may not see any difference, hardly any difference at all, if any, on that patient. Well, why? Because there's such bad inflammation going on that their lungs can't respond to beta stimulation. The inflammation is speaking so loud that the lungs can't even understand the beta-2 stimulation at this point, right? So you need to decrease inflammation before those bronchodilators are really going to be highly effective on that patient. So the whole thing here, when we're looking at this point number 2 here, suppression of inflammatory factors, is to prevent the cascade by inhibiting phospholipase, right? So we're trying to suppress that cascade, right, by inhibiting phospholipase. So if we can stop it there, right, we can stop that inflammatory pathway, we can mitigate as much as possible to really help this patient get a little bit better under control, to help that inflammatory pathway from overtaking their ability to breathe. So what are some indications for inhaled steroids or for steroids in general? The big one's going to be maintenance and control of asthma. Maintenance and control of asthma is going to be your first one here. It's been shown to have improved symptoms, improve their daily symptoms and exacerbations. So that's one thing that we know for sure. And the big thing is going to be educating them as well. And then the second one here is maintenance and control of chronic obstructive pulmonary disease. And remember, this is in your sort of step 2, step 3 area where we're starting to look at inhaled corticosteroids for those patients. And like I said there's been shown little effect on their pulmonary function values, but it's been shown to have better symptom, less exacerbations, and improved symptoms throughout their course when they're on these. So if you're looking for, hey, what happens to their PFTs when they're on this? Well, nothing really much changes there, but the big difference is more in their symptom management and exacerbations, their number of exacerbations. All right, so let's talk about aerosolized corticosteroids. The big ones that you'll see out there is beclomethasone or QVAR, flunicoside or Aerospan, So ticozone propionate, right, Flovent, that's the one I've been picking on. Budesonide or Pulmicort, and then mometazone, which is Asthma, right, you'll see out there. You'll even see these as combinations. So when we're looking at this one, budesonide actually also comes in a small volume nebulizer, right? That's the one that comes in a nebulized dose. And then I believe mometazone comes in a soft mist inhaler as well. So this one has a soft mist inhaler as well. But when we're looking at budesonide or Pulmicort, in theory, it can be mixed with bronchodilators, and you'll see different debates out there. You can mix it with bronchodilators. You'll see some facilities that do not mix it with any other medications. So just be aware, different hospitals might have different policies. I've seen it both ways. It's just very hard to really say that it's something that you need to do one way or the other, because the evidence, as far as I'm aware of, says that there's no chemical structure change. However, there is a precipitate that is formed chemically when you do this, so some places may not do this, so some places may do it by itself. The other thing about that small volume nebulizer, it's usually when Pulmicort is given, it's usually given in what's called a PARI-neb. PARI-nebs, if you want to Google image it real quick while you're listening to this, a PARI-neb. The PARI-neb is designed to nebulize very, very small MMADs. So it's designed to nebulize at a smaller MMAD than a regular small volume nebulizer. So small volume nebulizers, the ideal therapeutic MMAD, mass medium aerodynamic diameter for an albuterol or bronchodilator, is 3 to 5 microns. When we get down to the smaller airways, we're looking at 1.2 microns. We're looking at a much smaller micron size. Well, that's exactly what the PARI-neb does, is it nebulizes at a much smaller MMAD, and so that one gets to the deeper deposition of the lungs. Well, you have more beta-2 responsiveness in your larger to medium airways than you do in your smaller airways, because remember, your tissue transitions as you go down the tracheobronchial tree. So the question there that some people also arise or debate about, and I'm just giving you the debate, I'm not telling you one way or the other, is that if you do mix it with PARI-neb, if you do a bronchodilator with a PARI-neb, that you might get less of that medication, the bronchodilator medication, deposited in those larger or medium airways. Or if you mix them both into a regular small volume neb, then you don't get as much Pulmicort to the smaller airways, which is where most of the inflammation is, in those smaller transition/respiratory zone airways. So I'm just giving you both sides of the coin on that one, so you're well informed of the debate out there. As always, follow your hospital's policy and procedure, and then pay attention to what the current evidence says out there. I'm not sure when you'll be listening to this, but something to pay attention there too. When we're looking at combinations, right? Combinations, what we talked about there a little bit, a slide or two ago. This is when we're doing step 3 or higher. Step 3 or higher. Remember that? We were talking about that with the asthma. Step 3 or higher. And this has been shown to improve lung function and symptom control when we're doing it with those patients. Lung function and symptom control. And some ones in this category include Advair, Dulera, Symbicort, which is very, very common. This is a very common one at the time of this. And even Briolipta, right? You'll see these out there as well. So important to understand. You'll see those combination drugs out there. And then obviously understand when they're indicated for, and then how they work, right? What are they mixed with? So let's talk about systemic steroids versus aerosolized corticosteroids. So when we're looking at systemic steroids, we're looking at oral or IV steroids. So hydrocortisone is one that we've seen out there, and it's a parenteral route. It's also a topical, right, that you'll see out there as well. People use it for things like rashes and stuff like that. Cortisone is one of those ones that you'll see out there. Prednisone is the most popular oral steroid, so oral pred, right? If you hear me talk about oral prednisone, that's oral prednisone. And it's usually 3 to 4 times the anti-inflammatory effect of hydrocortisone, right? So it's much more potent. right? Much more potent than hydrocortisone. So prednisone can be taken PO, it can be taken orally, right? So that's something that you'll see there as well. Prednisolone is the oral version, right? Prednisolone, right? So if you see these on your patient's medical administration record, that's what you're seeing there. Then you have your methylprednisone, which is your solumeterol, right? Solumeterol, which you've already heard me talk about. This one's given IV, and it's used for emergencies. So this is where the patient comes in the emergency department, so on and so forth, all right? And it has 4 to 5 times the anti-inflammatory effect. So very, very potent. It's very rapid onset and a short half-life. That's the big disadvantage here. But it does have a rapid onset, so the idea is to help control them sooner on than later. And then finally on this list is dexamethasone or Decadron, right? And this one is oral or IV, and this one has 30 times the anti-inflammatory effect of hydrocortisone. 30 times what this guy has, right? That's pretty darn potent, and so you'll see a lot of people bring that out. Decadron or dexamethasone is a drug that they can even use on neonates, preterm neonates in RDS. There's a little debate about that, and we'll get to that in your perinatology class, but you'll see that they can bring out these stronger medications for different things. We can even use systemic steroids. Usually it's beclomethasone that we'll use for pregnancy. If we think the baby might have to be delivered early, we can give mom a shot of steroids, and that will help develop the baby's lungs to the point where they have less pulmonary issues when they're in the neonatal ICU. So there's some good advantages there systemically, and it's no harm, no foul. If we give mom the steroids and she doesn't deliver that baby early, it's no harm, no foul as far as that's concerned. It doesn't negatively harm the baby or mom. It's just the side effects, the risk versus benefits. Most of the time when they give it, they've determined that there's more risk of premature delivery, and so there's more benefit to giving it than risk of things like side effects. So they don't just give it to every mom that could have preterm kid, but they give it to the moms that are very, very likely to have a preterm delivery as well. So you'll see systemic steroids in that part of respiratory care as well, because it does help develop that baby's lungs, and we try to make sure it's in her system for at least 12 to 24 hours, hopefully. So what are some side effects of systemic drugs, systemic steroids especially? The first one that we're going to look at here is HPA suppression. HPA suppression. And this usually begins 1 day after systemic treatment, and it is significant, especially 1 week of oral therapy. You can really have the HPA suppression, so that's a pretty significant thing to be careful of. You're going to have to make sure that you taper off these medications, or you taper off the prednisone steroids. The body can't decipher between its own and what is taken. So if you have a lot of steroids that you're giving your body, the body is going to stop making its own steroids, and then you can have a rebound effect. So that's why you're going to see they'll do 6 pills, then 5 pills, then 4 pills, and 3 pills, and 2 pills, so on and so forth. So the tapering is important. You don't want to just go from having high-dose steroids to nothing, right? You're going to have a big issue there. So you need to taper off to help reduce HPA suppression. The next one here is going to be immunosuppression. Immunosuppression is going to be one of those things, because now what's your ability to fight infections if you reduce your inflammatory process, right? You're going to be immunosuppressed. So you're going to see that, and that's why some people that have transplants will be on medications that suppress it, their immune system, so that way they don't attack that new organ that they just got. The third one here is fluid retention. That's a pretty important one to pay attention to, and that's the picture over here, right? That's the picture over here. She doesn't look so happy in that second picture, but that fluid retention causes what's called moon face, and that's where we have an antagonization of the glucose uptake, and that will cause hyperglycemia, and then you can even see steroid diabetes with this, right? Steroid diabetes with this. So something to pay attention to, right, is that moon face. And then even muscle wasting, right? This is that next one, right? Because we're not producing as much steroids on ourselves. We're going to have things like insomnia, their inability to sleep, growth restriction, cataract formation, liver damage. There's a whole bunch of side effects that we just got to be careful of with systemic, right? This is the big slide. I want you to make a compare and contrast list between systemic and inhaled, right? That's going to help you understand the differences between the two, why we tend to go inhaled if we can, and why systemic is usually for emergency scenarios. And that's going to help you avoid any confusion between systemic and inhaled steroids. So let's talk about inhaled steroids. So side effects of inhaled steroids are very localized, very localized, which is awesome because it's considered topical. So fungal infections like Candida albicans, I had a doctor call it Candida, but Candida albicans. So fungal infections are going to be your big one. So what do we do with those patients? We need to educate them on things like rinsing their mouth, brushing their teeth afterwards, eating their meals after, right, and then brushing their teeth after that, right, to make sure that everything's moved out. I've seen people say live culture yogurt, right, there's just a bunch of stuff that goes on there, but making sure they're rinsing their mouth afterwards is going to be the big thing. Other things that you could see is dysphonia, so they could have their voice cracking and trouble there. Asthma, you can see that cough and bronchospasm. And that's because you can irritate the airways when you're giving out a medication, right? Especially if it's a dry powder. You could easily irritate the airways and cause an inflammatory pathway, right? So that's always a potential side effect because it is topical there. Fungal infections, dysphonia, cough, growth retardation as well. But understand with all of these, we're looking at that risk versus benefit ratio. All right, and if there's more benefits to doing it, is there things we can do with growth retardation or growth restriction? Absolutely. We can do HGH, right? Human growth hormone, right? For good things, right? The things we can do to mitigate the risks of fungal infections and all that. Absolutely, right? So when we're looking at what's the risk versus benefit ratio, right? Which one is really going to be appropriate for each individual patient? Is there more risks than benefits, or is there more benefits than risks? And if there is, how do we mitigate those risks if there's more benefits, right? Nasal-wise, they do nasal steroids, right, for the people with allergic rhinitis, things like that. They can develop things like nasal polyps. They can develop allergies to it, cough. They can have a chronic rhinitis, right? A chronic runny nose if they discontinue it suddenly. Could be another thing that you can see out of these individuals.